Hello and welcome back to Forbidden Talk, a discursive programme tackling social taboo topics in the Middle East. My name is Anna Delaney, and this week we'll be looking at mental health in the Middle East. Over the next hour, I'll be joined by a panel of experts and we'll be evaluating the current state of the mental health care system in the Middle East and considering how mental health is perceived in the region. We'll be analysing the various stigma and challenges that drive an individual to prefer to suffer in silence than to seek help. We'll also be taking a close look at how the trauma of war, displacement and occupation can affect one's mental health. At this point, I'd like to welcome my studio guests, Gona Saeed, advocate for Middle Eastern women's rights and co-founder at Kurdish and Middle Eastern Women's Organisation in Britain, and Dr. Najem Al-Falahe, consultant, psychiatrist and neurophysiologist. Welcome both of you to the programme.
Welcome.
But before we get started, let's take a look at this brief report.
In the West, mental health is becoming more socially accepted and better understood medically. However, in the Middle East, stigma and silence often prohibit discussion of depression and associated illnesses such as suicide attempts, self-harming, eating disorders, alcoholism and drug addiction. According to Global Health Middle East, 10% of the people worldwide are affected and suffer from mental health disorders, and the rates of depression and anxiety are greater in the Middle East than anywhere else in the world. Political and social unrest, a relentless cycle of economic instability, gender bias and loneliness are attributed to the high rates of mental illness in the region. As the conflict in Syria goes on, health officials are concerned depression rates and other psychological disorders associated with the stress and trauma of war will continue to increase. In Lebanon, where there are more than 800,000 registered refugees, the International Medical Corps said severe depression and anxiety were common. Between social and cultural stigmas and a lack of mental health care, diagnosis, assistance and mental improvement are hard to come by in the Middle East. Furthermore, traditional religious healers are often preferred over Western-style therapy and medicine. With negative attitudes towards mental health so heavily entrenched in the Middle Eastern society, how long will it take before the taboo can be broken?
Al-Falahe, before we talk about the Middle East, what should we be mindful of when we're discussing mental health from a psychiatrist's perspective?
I think it is important to think about 4 important points. The first point is the definition of the WHO. No health at all without mental health. So mental health is essential in our life. Number 2, the brain is an organ. As we get an illness in our lungs and we start coughing, we need to think that the brain can get ill. And it is the most complex organ that we are dealing with. Number 3 is the stigma in the Middle East that we started discussing now. And the 4th is the percent of people in the Middle East who are suffering because it is traumatized societies.
Okay, we'll come back to what those trauma are in more detail. But Gona Saeed, how easy is it to gain access to health care for mental health issues in the Middle East?
I think before you talk about access, we need to talk about what kind of mental health care does exist for people to access. Of course, also we are talking about a region that is a very, very large place with many countries, some which are stable and some which live in a period of war, basically, where they have very, very different responses to people's mental health, and there might be, I'm sure there is different mental health care everywhere. But generally speaking, mental health is still a big stigma, is still a taboo. People don't get help, don't access what is available easily. They don't talk about it. Also, I think what we have in the mental health care is a very, very large gap between in the services for people who fall in the large line between sane and insane. Because generally speaking about mental health in the Middle East, you will be talking about people who considered insane totally, or sorry for using the word crazy. But then and then sane people who are fully aware of their surrounding and everything. But then there are as we know, there are so many mental health conditions, so many psychological disorders that fall into that line, that people with treatment, with the care and with the health care, they could get treated, they could get well. And I think we have a very huge gap in mental health care in the Middle East for those large number of people who have mental health. So therefore, I'm saying, again, going back to your question about access to healthcare, first we need to know what kind of healthcare is available. To my knowledge, there isn't much available for people who might do with treatment.
I think to complete the picture, it is important when we are talking about mental health, we don't forget addiction. Because the biggest problem, what is happening now in the Middle East, is wars in many areas. And the Middle East is on the Silk Road regarding the addiction trafficking. Iraq, which we didn't have more or less any addiction problems in regarding drugs addiction and heroin. Maybe the colleague knows about it. In the last 10 years, we are getting more and more cases, and the society has been affected. In the Gulf, the Gulf is targeted regarding drug dealers because of the wealth and because of political issues.
And Dr. Al-Falahe, we will talk about addiction and trauma of war as well. But just talking about the status of the healthcare system in the Middle East in general, how advanced is psychotherapy? How advanced is psychiatry and therapy? And how much investment is put into these structures?
The biggest problem regarding mental health in most of our countries in the Middle East, it comes in the last point in the list of care, of health care. In most of our countries, the available services are extremely limited. And when there are a number of psychiatrists, there are not enough number of psychologists. Really, it is not only the Middle East. We are suffering. We were discussing, my colleague and I, before the program. Arabic-speaking psychologists and Kurdish-speaking psychologists, Iranian-speaking psychologists are very limited. Of course, psychiatrists also very limited. So it needs to be a new structure, a new drive. Plus, also, we don't need to forget the voluntary organization. How can we help recruiting them in the activities? Where my colleague will give us more information about that.
Well,
if I
yes.
just add a little bit, I think the care relies on the families mainly in the first place. Now, we do have some sanctioning institutions in many of the Middle Eastern countries, but that's about it. We have some psychiatrists and some sanctioning institutions. So when families can't take it anymore, or when the people with mental illness become dangerous to themselves or to others around them, they will be sent to the mental institutions to be sanctions. And there they wouldn't get treatment to get really well. It's going to become a prison for them. And that's about it, I would say.
Okay. Well,
of course, there are few institutes. But sometimes the sanctioning institutions is not a hospital, sometimes at home. I have seen patients, because of mental health, they have been sitting in a small room or a small flat at home without getting the right help. So this is also another thing, how to deal with that. The other area which is taking big part are the prisons. So many people, they get convicted and sit in prison, but at the same time they are having a problem with mental health, and they need some help with that.
Well, I just wanted to ask you both about what's the difference between the way the West sees mental health and the way the Middle East views mental health? Maybe Gona, you can start.
Okay, well, if I start up until maybe, say, about 30 years ago, maybe the West was dealing with people with mental health issues in similar ways. And this is about the stigma surrounding it. This is about the way we kind of give hope to people to get treated. I think the difference now is very large, and it goes from top to bottom, basically. When I say top, I mean in terms of policies, in terms of protecting the rights of people with mental illnesses in the law, in constitutions. And I think this is a gap that we have in the Middle East. You don't see those kind of rights recognized or protected. So that's from the top. And if you come down to the bottom, of course, this is about general awareness, it's about the stigma, it's about public awareness of different mental health issues, of levels of, mentally unwell people, and also about the opportunities that with the right care and with the right treatment, people will get well, they could perfectly live a normal life, they could get married, they could have families. So you don't see those kind of awareness, and generally in the Middle East, there isn't any comfort around talking about a family member with mental health.
And on that note about awareness, I mean, how free do people feel they are to discuss mental health? How open are they about discussing it?
They usually don't discuss it as a mental health issue. They usually discuss it as evil eye or jinn, a demon affecting them. So this is the areas, and they are either suffering in silence or going to the sheikh or the imam to take care of them. And it is important to think about it, that there is a gap, a time gap between beginning of the illness until they reach us, if they reach us. So few years of suffering if they reach us. And there are so many people that don't come to treatments.
Gurna, did you have anything to add to the openness of discussing mental health?
I think all I could add is that if we want to treat people with mental health, and if we want to provide some kind of humanly ways of helping people with mental health in the Middle East, we need a radical change from the top to the bottom, basically. As I said earlier, from our policies, legislation, from the state, and also to the society, to the institutions, and also to invest in that. Because I think, according to the data and statistics, you might know that the prevalence of people with mental health is very, very high, and is higher in the world, in the Middle East. So therefore, you need investment, you need research, you need institutions, and you need care for these people.
The other area which is needed, I think, prominent people start to go out and talk about mental health.
Yes.
I think this is the success of the West regarding killing the stigma. Okay. Singers, actors, writers are needed to come forward and discuss these issues, which are important, because as we know, there are many singers who are suffering, and writers who are suffering, politicians who are suffering, because they are part of the society.
Okay. To help us further explore the barriers to mental health care in the Arab world, we'd like to welcome Dr. Laith Nasir in Nebraska, who has co-edited Caring for Arab Patients, a biopsychosocial approach. Welcome, Dr. Nasir, to the programme.
Thank you.
Doctor, you've conducted a special study in Jordan on depression. Could you tell us about your findings?
So a number of years ago, we had conducted a study with primary care physicians in primary care setting, looking at barriers to the diagnosis and treatment of depression in Jordan. And briefly, our conclusions were that physicians suffered from a number of issues. These included lack of education or models of how to conceptualize depression in the primary care setting. They also had a lack of availability of appropriate therapies that included counseling and obviously medications. Another thing that's seen really all over the world is competing clinical demands. So in the primary care setting, you're not just dealing with an obvious somebody with an obvious mental illness. This is a problem all over the world. is that the difference between people who present to primary care and people who present to a specialty setting is that in primary care, very few patients have actually accepted that they have a mental illness. They might not even be aware of that, or they may be aware of it and resisting it, whereas virtually everybody who goes to a mental health institution or a mental health provider has already accepted that fact.
And Dr. Nasser, what are some of the cultural and environmental barriers in Arab society that prohibit access to adequate mental health care?
Mm-hmm. Well, and first and foremost is stigma, obviously. It is a stigma, obviously, to suffer from mental health issues, really anywhere in the world, and I think it's magnified in many Arab countries because there is such a focus on the individual as being kind of responsible to uphold the honor and integrity of the family and so on and so forth. And if it's suspected that somehow you are responsible in some way to injure that integrity or the loyalty of the family, that's a very, very difficult situation. So, for example, women who are depressed, or even men who are depressed, if people find out, this may have implications for their prospects for marriage. I mean, particularly among women, obviously, but this could extend to all members of the family. People will shun the family and say, gosh, this family is not a good family to marry into. So people obviously are fearful. The other thing is that there's a little bit of a mismatch, and I think this is really important for us to focus on, is that in a way, the way that mental health issues have been conceptualized in many countries, not only Arab countries, but in many other countries, is that they tend to be conceptualized as external forces. And I think Dr. Al-Falahe talked about this when he was talking about the evil eye and the jinn and so on and so forth. In this model, there are external forces acting on the individual. And in that way, it actually destigmatizes, to some extent, the issue. It's not your fault. You are being acted on by an external force. And so how do we leverage that beneficial effect and yet have the effects that we want, which is to treat the individual and so on and so forth? That's a difficult balancing act, but I think when we talk about sustainability of these mental health models, we have to really include, to a great degree, the cultural milieu and the cultural approach that people take.
Dr. Nasser, I'm just going to bring in Dr. Al-Falahe here. That's an interesting
I think that is extremely important. Thank you very much, Dr. Nasser, for this important issue. I had a patient yesterday, and he was telling me that he went to so many imams, and they were reading ruq'ah on him, and he was hoping all the time, for many years, for 15 years, he hoped that he will get the signs and symptoms of an evil eye or a jinn on him. But all these trials, he couldn't get it. So he said, I told him, why did you want to get this point? He told me, because if they found that there is an evil eye or jinn, they can treat me, but they couldn't. So that's why he came to get the treatment, and it was severe depression. So it is interesting in this aspect is the power from outside. The other important point, Dr. Nasser and Gona maybe can help me with that, is in England at least, that mental health, to reduce the stigma, it moved to be a celebrity. So many celebrities, I just mentioned previously, many celebrities comes to us, to the Priory Hospital. We are one of the leading hospitals regarding mental health in the UK, and they take the treatment. And even the people who are on their way to be celebrities, they are coming to the hospital just to say that I have been treated in the Priory and in their websites and Instagrams and.
Oh, so they're using it as PR.
Yeah.
Oh, right.
So this
so
is.
It's cool to.
It is cool,
to
but it depends on the diagnosis
Priory.
also.
Okay.
So if it is bipolar, yes, it is a very active and interesting diagnosis. But if it is personality disorder, then they are not looking at it the nice way.
Okay.
So I can sit in front of a celebrity and he or she push for the bipolar instead of another diagnosis.
And that's also, yes, that's true. That's seen in the West, is that there are, and I think you see it, so a number of years ago, certainly in the United States, people would come and request, for example, serotonin reuptake inhibitors for depression. Now you're seeing people self-diagnosing themselves, partly because of the media, with, for example, attention deficit disorder. So there is an awareness of the cultural acceptability of certain diagnoses over others, and this is very true. And how to bring that about in the Middle East is going to be, one of the challenges that
I think one of the important things, Dr. Nasser, if you allow me, and this question I have been asked by my patients and even people when meet, is that, am I really ill? Where is the area between normal situation and illness? And this is, it is easier with physical illness, with a cough or high fever or a fracture, but with mental illness, where is it? And usually help me, Dr. Nasser and Guna, usually I say it in a very simple way. If you are managing to deal with your daily life regarding your studies, your work, and you are enjoying your life, then things are in the right direction. If you have the difficulties, you are welcome to get some help. And really, most of the people who are coming to my clinic they have certain issues regarding, and they are not so complicated, regarding sleeping disorder, regarding depression, which they get help. And also when they come to our clinics, Dr. Nasser, they not only get help for the problem, but they get a tool of coping mechanisms that they can continue their life in a very nice and good way.
And Dr. Nasser, how is the stigma shown in the community? We've spoken about stigma today, but how is it manifested? And what are the consequences on the individual?
In most Arab countries, there's an imperative on the part of the individual to uphold the reputation of the family in every aspect. And so if you are perceived to fall down somehow and be seen as flawed or there's something wrong with you, that obviously impacts the family. And so it creates a great deal of pressure on the patient. Not only are they suffering from psychological symptoms, but they also are so afraid to be expelled from the family, essentially. And this really creates a great deal of difficulty. And I think, we're seeing this more and more, I believe, partially because of globalization and the associated culture change. So for one example is that women in the Middle East are now becoming much more well-educated. Well, this creates different expectations and different attitudes among women in general that kind of fly in the face of their traditional roles. and it also kind of takes them a little further away from their traditional roles. And so there's a great deal of pressure, social pressure, from all areas, and it's sometimes conscious and sometimes unconscious, that creates really this double burden on them. So, for example, they might be employed, but they're also expected to continue to take care of the family. They're also expected to bear a certain number of children. They may have to delay childbirth. They may have to reduce their fertility. And so in all these ways, it weakens them in the traditional sphere, as it were. And so if you want to look at depression as a manifestation, in many cases, a manifestation of cultural disconnection, cultural failure, a feeling that you're a failure. So in men, for example, it's often seen among people who are unemployed because, the man's role is to go out and make money and be the breadwinner. And the woman's role is X, Y, and Z. And if people are not able to fulfill those cultural roles, or they don't have an opportunity to change those roles, that's when they often will fall into a situation of depression.
Dr. Nasser, can I just bring in Gona at this point, the cultural roles, just from a woman's perspective? I'd love to ask you about that.
Well, I think Dr. Nasser has touched really greatly on that. And if you go back to Middle East, looking at women's situation and the causes of mental disorder, you could see that women fall the majority of victims for those causes, basically. That's in terms of the social pressure, in terms of discrimination, in terms of the traditional role that has been imposed on women and there is no way out of it. And also when a woman falls ill into a mental disorder, then there is another chapter after that, like protecting that woman to not fall into exploitation, to not go out, imprisoning her. I mean, we've had as an organization a woman in Iraq who was chained for 8 years in a bathroom, basically, outside, just because she had mental disorder and just because the family actually thought they are protecting her from being exploited, from being raped, from going out. And we've had other stories where women with mental disorder, they were sent out and then they were raped outside, and then all these tragic stories. So going back to that, how much of that victimization falls into women, it is enormous, basically. And that's because, to a degree, I mean, she's expected, even though with the mental illness, even though with some disorder, she's expected still to take all the obligations as a normal, traditional woman and to oblige to them, basically. And what I mean is, as a person, if you have a broken leg, you wouldn't be asked to walk on them. But when you have a mental disorder, you are still asked to look after yourself, to be, you will be pushed into pretending that you are fine, basically. And I think women get that a lot, enormously a lot.
I suppose the lack of visibility is obviously...
Exactly. You still have to raise the children, you still have to do the housework, you still have to do your other duties as a woman, you still have to oblige to everything else, although you really need treatment.
I think if we move from, which is extremely important, Guna is saying, if we move from severe mental illness, like Dr. Nasser is research talking about family doctors, but I want to move it one step earlier. When I worked in the Middle East, we used to have at least one lady, one girl comes per night with epileptic-like attack. And the patient comes and we diagnose her as a type of hysteria and support her. When I started working in the West, and the first night I was at the A&E, in the acute service, no girls with epileptic-like attacks. The second night, the same, and I asked them, they say, this doesn't exist. The epileptic-like attacks or hysteria is caused by huge pressure from different sides on the young girls. Usually they come 17, 18 years of age. And this is huge pressure on them, and they don't know how to deal with it. And last week came to my clinic a patient from the Middle East, a lady, she was just 17, and with epileptic-like attack. That is very difficult to deal with. But the important thing that she understand her role and understand the pressures on her. So this is extremely important area that we need to really do some research on it in the Middle East, because it is unique now. We don't see it a lot in the West.
That's very interesting.
That's very true. Actually, it's very interesting because a number of studies were done on this. So Dr. Tawfiq Tarak, I'm not sure if you're familiar with him, he actually taught me psychiatry in medical school. And he had done some research on exactly this dissociative states that particularly young girls would come to the emergency room with. And he was actually able to map that there was a tremendous increase in these cases around the time of final examinations from school. And so it kind of illustrates that, there's so much pressure on these young women, and they really have no other outlet except really to, in a way, this is a cry for help, is to go into this dissociative state.
Now I'd like to welcome over Skype Sheikh Zayed Al-Ubaidi, religious healer and spiritual advisor based in London, to give us an insight into the role religion plays in the treatment of mental health sufferers. Thank you for joining us, Sheikh Zayed.
Thank you, Anna, and thanks for your guest as well.
Sheikh Zayed, can you talk to us about how Islam views mental health?
Well, actually, first of all, we need to know that the Islam guided us to a new methodology in dealing with diseases, including psychological issues, by looking at it as trials and tests from Allah subhanahu wa ta'ala. And that applies to everyone, even to the prophets, the most beloved people to Allah subhanahu wa ta'ala. This actually minimizes the crisis. The other thing is to compare yourself to those who are worse in their situation than you. For example, if you have an example is a benign cancer, look at those who have malignant cancer. Therefore, our Prophet, peace be upon him, said, look at those who are beneath you and do not look at those who are above you, for it is more suitable that you should not consider as less the blessing of Allah.
Mm-hmm. So it's gratitude.
A gratitude. Then
okay.
we look at it as well as a source of removing sins. So when any diseases befalls anyone.
Yeah, okay.
This beneath and up is important, but level of suffering regarding the illness is extremely important.
Yes, yes, exactly.
Mm-hmm. And can you explain what are jinns that we mentioned briefly today, but and how you work with them?
With people, yeah. I used to deal with people affected by jinn. I don't have any access to jinn because that's a one-way system, and it's reciprocal benefits if you deal with them. In order to gain something from jinn, you need to pay something for them as well. Most probably, or in most cases, you need to do something bad to your religion or to your belief or to your faith. Usually, actually, when I have people actually suffering from certain things, for example, they see something, or at night, or they are talking to someone, invisible thing, then I need to recite Quran for them. Usually when you recite Quran to someone, usually normal people, they enjoy it. But when you have a reaction in your body, like tiredness, numbness, headache, yawning, crying, or becoming unconscious, that means you have something wrong with you, which is actually spiritually. Islam looks at a human being that consists of two parts, physical and spiritual. And you need to feed both of them, both parts. And you need to feed them with the right food. Otherwise, you fall sick either in your body or spiritually.
With dry food?
Right. No, with the right
food.
No, the right food, yeah.
Right, yeah.
The right food. And
so people, a good diet.
Most people actually they actually concern about the physical what you call entity of this life, which therefore you find them very keenness and they're very keen and greedy in actually collecting things and to satisfy their desires, which means that they are feeding their body, they're ignoring their soul. Most those people actually susceptible to have a psychological problem, whether it's spiritually or mentally.
So the more pure you are, the less likely you are to be victimized, I suppose.
Yes, actually, if you are, Islam asks people to be careful about everything, and there are a lot of precautions, which I mentioned earlier. There are precautions before you fall sick. There are we have a lot of proofs that all people they have actually hardship in their life, calamities and problems. Nobody actually can have like exemption of that, even the prophets. Therefore, you'll find the most religious people who understand Islam correctly. I put two lines under correctly. They don't get actually depressed, and because they understand everything, even when they actually have hardship or crisis in their life, they know how to deal with it.
Sheikh Ziad, I know you work closely with Dr. Al-Falahe. Can you talk to us about that process? And I'd like to hear from both sides.
I want to say one thing. Sorry, Sheikh Ziad. We are talking about pureness and also harmony. Islam giving harmony to the person. A person who is praying 5 days a week, he is meditating 5 days a week, leaving the whole life activity and focusing on one important issue. Regarding giving an example of a patient, I referred let's call him Mr. M to
Mr. M.
Ziad, and he
Yes.
can give us some information about the meeting when I was with the patient also.
Actually, yeah, no problem. Well, actually, we were working on a patient. His name Mr. M, and actually, before I talk about that, I just want to highlight on one point. The most important thing, vital and necessary issue in any psychological problem is to get the patient out of his hiding place and let him speak up, which is very important. The other point, because actually that point, if you can reach that point, will prevent any crisis happen to that patient to commit suicide or to do any bad things to himself, to hurt himself. The other thing is very important to combine between the spiritual, which you can say, consultant and a mental consultant as well, psychiatric doctor, to achieve the best result. Me and Dr. Al-Falahe actually applying that strategy in our work. Once actually Dr. Al-Falahe he come with Mr. M, and after I recited Quran on him, he had a shaking hands. His hand was actually moving around and shaking. Nobody. It's very hard. It's very hard to stop it because it's not his power. And I believe he was actually possessed by jinn. Beside, actually, he's got psychological illness as well. Because some people, they might have both of them. Some people, they have one of them only. If there is no react on any, I've just mentioned earlier, like headache, tiredness, numbness, yawning, crying, becoming unconscious. If there is no any reaction, it means that this person, he's got psychological problem and he needs to see a psychiatric doctor. Nothing to do with me.
Well, thank you, Sheikh Ziad. We've got to leave it there, but thank you so much for giving us that insight.
Okay, most welcome. Thank you very much.
And Gona, we were just talking about the role family plays in this whole structure, this very complex structure of mental health care. So how can it affect the family's structure? And is there a culture of blame within the family?
Well, absolutely. I mean, it depends definitely of the status of that family. It depends on their financial status, of whether they are affected by poverty, which, majority of families in the Middle East, I could say majority of people are. It depends on the level of education, of the level of support they get from the wider community, from their neighbors, from their relatives as well. And also it depends on who is the person within the structure of that family with the mental health. So, for example, is it the head of the family? Is it a younger person? Is it a child, or is it a woman? So all these, because as you might know, I think because of the complex structures of families and some what I call discrimination, the imbalance of power in the families within majority of Middle Eastern families, I would say the status of each individual different, and when they suffer from mental health, the way the family react, it differs a lot as well. It is different as well. For example, if it's the head of the family, the person who was in the status of power all the time, then everybody will be panicking. The stigma will be much, much stronger. How are they going to get this out? What will happen to the family's reputation, to the family status? If it's a younger person, that would be much easier. Again, I explained earlier, if it's a woman affected in the family, then the whole, rather than focusing on treatment and care for her, the whole focus will go into protecting that family from exploitation, from whether this woman is going to get out, whether her mental health is going to affect the family's reputation, the family's honor, or all this and that. So I think it has a lot to do with the status of that family. It's very complicated, as you said, but also it has a lot to do with the general awareness, with the society's awareness as well. I could give you examples of, as I said, a person with mental health within a family who lived perfectly a good life, got married, got the support they need from their family, and then you could get examples, as I said earlier, from a woman who was chained into a bathroom in a bathroom chained for 8 years, just in case if she gets out, with no care, with no respect, with no treatment at all. So you will see different responses, but at the end, I think there is this big gap that the state doesn't take responsibility for the treatment of people. So the family take that responsibility, and they could do as much, basically. They can't do everything. They could only do some, and that depends on all the things I talked about, on how much they can do, how much they could offer that person.
I think it's important to emphasize that the family either with you or against you in the treatment process.
Well, moving on now to war and occupation, I just want to, obviously we are surrounded and we see images of horrific things happening at the moment, but can you just hone in more on what are the consequences on one's mental health? What's the impact?
It is simply, as we mentioned, it's a traumatized society we are dealing with. And usually, if we want to address these issues, we need to address it on more than one level, on individual level and also on a group level regarding the treatment. So we need to start developing group treatments in our countries more and more. And group treatment, I have been in the Middle East to see organizations and work. Group treatment, one of the important things, and in psychiatry in general, one of the important things is confidentiality. So you need to create a confidentiality and a clear structure in order to move to group treatment. So these are the biggest problem in our societies.
Well, with us now to explore this issue further is Dr. Inka Weisbecker, Global Mental Health and Psychosocial Advisor at International Medical Corps in Washington, D.C. International Medical Corps delivers life-saving healthcare in emergencies for people affected by disaster or conflict. Thank you for joining us, Dr. Weisbecker.
Yeah, of course. Thank you for having me.
Dr. Weisbecker, with over 4.8 million Syrian people seeking refuge in neighbouring countries, what are the most prevalent mental health problems affecting refugees?
Yeah, that's a really good question. And actually, in all humanitarian crises, including the Syrian crisis, obviously it's affecting people psychologically. And we see many stress-related problems that people are having, such as problems sleeping, nightmares, somatic complaints like headaches, feeling hopeless, feeling anxious. And it's important to remember that all of these are actually normal reactions given the current situation that people are finding themselves in. So these reactions do not mean that people actually are experiencing mental illness. However, a certain percentage of people will actually develop mental illness, and some people are already having pre-existing mental disorders as well that may have even existed before the crisis. It's really hard to find good prevalence data on the Syrian crisis or in other humanitarian crises because it's very difficult to actually distinguish as well mental illness from normal stress reactions with simple survey research, which some people are trying to do. And sometimes we see overestimates of prevalences as well, because there are a lot of people experiencing normal stress reactions, especially with the crisis that continues, so that people actually may not be able to recover and have these reactions subside, but continue experiencing stress. So there are some general estimates from the World Health Organizations for humanitarian crises that say that about 20% of people will experience common mental disorders like depression or anxiety. And that's up from a baseline of about 10%, which we see in any population. And severe mental disorders like psychotic disorders can increase from about 2 to 3% to up to 4%. So these are general numbers that we often refer to. I should also, one more thing about prevalence. We are also having actually mental health services available in the region, and we have some data from that, which of course is not the same as prevalence, but we can say that from the patients that we see in our clinics for mental health problems, the most frequent problem are emotional disorders such as depression and anxiety disorders, followed by epilepsy and psychotic disorders. And in children, the most common are developmental disorders.
And Dr. Weisbecker, can you talk us through how International Medical Corps provide mental health support to the refugees and migrants affected by the conflict?
Yeah, absolutely. In all the countries where we work, Syria, Jordan, Lebanon, Turkey, Iraq, all the systems are obviously very overwhelmed with the refugee crisis, and that includes health systems and mental health systems. In many of these countries, mental health systems were not very strong in the first place. So now with the Syria crisis, there's especially an urgency to provide mental health services. There are not enough psychiatrists, there are not enough trained psychologists or trained social workers. The World Health Organization actually recommends training of general health care providers like doctors and nurses in mental health so that they can identify and manage mental health problems at the primary health care level where a lot of people come for care. And that's an approach that's already being done and scaled up worldwide by the World Health Organization and others, and something that we're doing within the refugee crisis as well. So we basically are building the capacity of general health care providers who are working at Ministry of Health clinics, for example, in affected countries. And we're building their capacity to, for example, diagnose and treat depression, anxiety disorders, developmental disorders, epilepsy, psychotic disorders. So that basically means that people who are coming to general health care facilities who might not even know that they have depression, but they might present with a headache, for example, they can more easily be identified and treated. At the same time, you also have psychosocial workers who are people with psychology or sociology, social work backgrounds who are working with us in affected countries who are from those countries, or sometimes even Syrian refugees themselves who are getting very basic training in psychosocial support and also in how to identify and connect people to needed services and conducting basic case management. So these psychosocial workers make sure that people get the many services and the care they need. It's very rare that we see people who just have a mental health problem and nothing else. A lot of time people actually have medical problems. They may be under threat of being evicted by their landlords because of their mental health problems. There might be violence in the home. So our psychosocial workers make sure that Syrian refugees and Syrians in general have access to all these different services as well, not just mental health services. So it's really a comprehensive approach. I just want to mention as
Dr.
well.
Weisbecker, I've got to move on to the next question, but we've spoken quite a lot about the stigma attached to mental health among Middle Eastern culture. How, as a Western NGO, do you work with these cultural sensitivities?
Mm-hmm. Yeah, that's a good question. And I should mention that as an organization with International Medical Corps, actually 91% of our staff are nationals from the country where we're working, and only 9% are internationals or expats. And that even within our leadership, although we have headquarters in the UK and in DC, actually a lot of people are from the Middle East or African countries, Asian countries. So we're pretty diverse. But it's also important to keep in mind that we don't actually send, for example, people working in the West to work in the Middle East directly with clients. Rather, we have people who are going into the Middle East and helping build the capacity of the people who are already living and working there, of doctors, of nurses, of psychologists, of social workers, so that people from that culture, including Syrians themselves, get basic training according to their expertise and their level of knowledge, so that they can serve the population there. So we're really there as partners, as supporters, as those who build capacity. We work very closely with governments, with local organizations. In Jordan, for example, we partner with the Jordan Health Aid Society. We have local partners in all the countries where we work. And stigma, of course, is a really important issue in all the countries we work, also in the Middle East. So we can't just wait for people to come to a psychologist or psychiatrist on their own. That's often very unlikely. So we have activities, for example, we have child-friendly spaces, youth-friendly spaces, community centers where people can take computer classes, English classes, engage in activities, and can learn more about mental health, where to find support, can talk with people there. So the first point of contact is often a psychosocial worker or people who engage in activities.
Dr. Weisbecker, I'd just like to ask a question that Gona Saeed actually suggested. Have you worked with Yazidi women on site?
Me personally, not. I'm basically in DC overseeing our programs, but we have people on the ground who are working with all the affected populations.
And I want to also touch upon children. I mean, there are 5.6 million children affected by the crisis. What does International Medical Corps consider to be the best way to help them move forward and attain the futures that they deserve?
Yeah, absolutely. For children, obviously, it's very important to have a safe and supportive environment where they can learn and develop. And there, for example, schools and educational opportunities are very much key. We've done one assessment in Jordan, for example, among children and youth, asking about stressors they're experiencing. And the most common stressor was actually bullying in schools, which for them was worse than even experiences they've had before coming to Jordan. So that's something we need to take very seriously to really make schools friendly and welcoming to refugees, but also make sure that youth, for example, have educational opportunities and livelihood opportunities as well. We also need to support parents. It's very important to not just focus on children, but to recognize that parents are key to helping children and that parents need help in accessing basic needs, having livelihoods, jobs, knowing how to deal with stress, parenting. In Turkey, for example, we're piloting a parenting program to help parents who have children with developmental disorders, which I already mentioned is very common among the population we serve. So supporting parents is one key to support children. And then lastly, of course, helping those who deal with children. We have child-friendly spaces, youth-friendly programs, for example, that those who are staffing these programs or who are in school can really identify children who need more help, who need more specialized mental health services or protection support, that those children can be identified wherever they are and connected effectively to the services that they need.
Dr. Weisbecker, we've got to leave it there, but thank you so much for your informative expertise today. Thank you.
Of course, no problem. Thank you.
Dr. Al-Falahe, the Middle East has had its fair share of dictatorship. I mean, how is it living under the threat of the fear on the impact of living under a dictator on one's mental health? How does that affect?
I think three important areas one need to have in mind that can create traumatized societies. Dictatorships, wars, and a huge economical uncertainty. All this instability gives you a traumatic society. And our colleague is pointing to important points regarding dealing with refugees. One area which is important also, there are 3 points also here. It is the pre-existing psychiatric illness that our colleague mentioned. There is the trauma and moving from one country to the other. And the third point, which is extremely important, is ongoing problems. Sometimes when I had a patient who has been traumatized twice by being in a prison and tortured, but he didn't come to us. But the minute that he had sleeping problems because he has a new child, he came to us. Correcting the situation made things completely different, and he returned back to his work. So it is important not to overdiagnose, and it is important to support the patient at the situation now.
Well, I'm going to welcome our next and final Skype guest. Dr. Jabr is a leading psychiatrist, psychotherapist, and a trainer in practicing in the public and the private sectors within Palestine, in her native city of Jerusalem, and in the West Bank. Dr. Jabr, how has the mental health of Palestinians been affected by the occupation?
Well, thank you for having me on this show. And in fact, Palestinians have been suffering from chronic oppression and fluctuating intensity of violence from time to time that touches almost every aspect of their life. It touches economy, development, education, health, including mental health. Psychosocial suffering like stress, grief, and traumatic reactions, increased anxiety, depression, are some of the responses to life under occupation. This in addition to a very common but less reported injury that is commonplace among many Palestinians. That's the injury of humiliation resulting from the daily friction and the daily interaction with the occupier.
And Dr. Jabr, how does the lack of Palestinian statehood affect people's mental health?
You know, Palestinians feel like unprotected. The lack of statehood and the dysfunction of the protection of the leadership in the face of the continuous Israeli aggression and international apathy towards Palestinians and all the harm that happens to Palestinians makes most Palestinians feel like orphans, unguided and unprotected. When Israelis harm Palestinians and enjoy total impunity, people want to take their right by their own hand. And this explains why you find the current phenomena in Palestine, where you find untrained, unarmed children going after a well-trained and unarmed Israeli soldier trying to stab him. It is because of the damage that happened to the role of the father over the years. And when the leadership cannot protect the people, when they behave like dysfunctional, unable to protect, it is the children who want to fill the vacuum and act as the leaders of this nation.
And you've been critical of foreign clinicians coming to occupied territories. Why is this?
Well, I'm critical of some foreign clinicians who come to Palestine with excitement about coloring their CV with war experiences and feel overconfident about bringing us methods and interventions that were developed in a more peaceful and in a more resourceful part of the world, in the West mainly, expecting that they will work for Palestinians in the context of occupied Palestine. On the other hand, I welcome foreign clinicians when they come here, when they come to Palestine, with solidarity and empathy, validating the Palestinian need to struggle to end the occupation, when they are sensitive to the political and the cultural context of the Palestinians, and when they are willing to learn from the Palestinian experience, to learn from this unique context. I do believe that our interventions and therapeutic techniques should develop in this unique context and not be imported from a different reality.
Dr. Jarb, I'm going to bring in Gona there because you're nodding away, and I think you appreciate that. I mean, I was sort of referring to taking Western style therapy out to, say, Palestine or the Middle East. What are the problems there?
I have to say that I agree with what our colleague here said in
Jarb.
regard to in regard to the models that are used, like in counselling and psychotherapy, and I certainly could see that in the even here in this country, in Britain, when the women come to our organisation for help and they need some sort of psychotherapy or counselling, we refer them. They don't stay on it. And that's because of some of the issues and barriers. They don't feel that it works for them. Personally, I think people's experiences has a lot to do with the way they react to treatment, especially to psychotherapy and to counseling treatment. So in this way, it means that a person in Palestine or in Iraq or a person who lived there and had their suffering or their trauma happen there, and now they need some counseling or psychotherapy to treat their well-being. It's not necessarily the same experience as a Western person who, as the doctor said, is they lived in a more peaceful, more resourceful place. And therefore, the methodology, the models that are used to treat them, maybe it doesn't work. The other issue is about the language. In this country, the women, again, you know, when you describe your situation, your emotional well-being, traumas that happen to you, or the way you feel about them, your nightmares, it's the last thing you need to think about is to interpret that into a second language in your mind. You need a space where you could talk in the language that you are best at. So you really need counseling or therapy in your own language as well. That's another issue. And as Dr. Al-Falahe said earlier, we have a lack of bilingual counselors, psychotherapists in this country, so therefore they are not meeting the demand of the mental health need of people from the other ethnic minorities in the country.
Dr. Jarb, but you've spoken about the impact of political prisoners returning to the family after years of imprisonment. In fact, you just mentioned the impact of the father. In what ways can their mental health be affected?
Well, let me first point to the fact that almost 30% of the Palestinian male, 30 to 40% of the Palestinian male population has been arrested, and torture and maltreatment is commonplace in Israeli prisons. And torture and maltreatment leave people with severe injuries and scars to their psyche. For a person, for example, these scars and injuries touch the person, and they touch the family and destructure the family, and consequently they intimidate the whole community. Some people come out of prison as shadows for the persons they were earlier in their lives. They come to the family, they find it extremely difficult to integrate. They come back to the family after 10 or 15 years of imprisonment. They found that the eldest son or the brother, the uncle of the children, took his role, became the father of that family. And it is difficult to change that structure because many years passed by, and because a severe damage has happened to this person who spent many years of life behind bars. This is also true for minors. We see in the experience of adolescents and minors, these children were arrested in extremely difficult conditions from their schools or from their homes, where the parents and the teachers failed to protect them. And they find it difficult once they are freed from prison to go back and be integrated in school or in their home, because the authority figure in home or in school, the teacher or the father, fail to protect them at a certain point, and it is difficult for them to accept the authority of these people again. So it's a big destructuring and disruptive experience for the home and for the community.
Dr. Jarab, we've got to leave it now, but thank you so much for your expertise and your time. Thank you.
Sure.
I want to ask you both finally, what needs to be done to make sure future generations have a better relationship with mental health and a better awareness and how it's perceived?
I think expectations regarding treatment is extremely important. Because as Guna mentioned, people are accepting and understanding the physical illness, but mental illness, they are not knowing a lot about it. And part of mental illness is chronic. And when we treat them, the family expect that the treatment will be for 1 month and it stops. And then when there is a relapse, they will blame themselves, they will blame the patient, they will blame the clinician, and also thinking of addiction as a treatment of more than 14 months in order to reach to a stability. Addiction is extremely important as part of mental illness. Otherwise, if we don't consider it and think about really treating it, it will be a big problem in front of us. The other thing is the mass media and awareness that this program, other programs, important figures, psychiatrists coming out and speaking about it. And stigma is not affecting only people not coming to treatment. The stigma affecting people that are in treatment because they cannot talk about it and they cannot get the right support from the school, from the families. So these are the points.
In addition to what the doctor said, I would say focus on prevention first, especially in the case of, again, I'll take it back to the social status of women. And prevention, the whole society from getting more into kind of mental ill disorders is about enhancing, improving the social status of women. That affects their children, that affects their family, and that's been proven by World Health Organization that the well-being of women affects the whole family. And also, of course, empowering them economically, empowering them socially. It's about also protection of the rights. I mentioned this earlier. People with mental illness or people with mental disorders are still people. They are not the illness. They are people. They have a condition. So they are still people with rights. They are people. They have to be protected. There has to be investment in the care, in the treatment. And I think state has to take responsibility for that because so far the main responsibility is on the family, and that's like a lottery. If you have a structured family, then you are fine. If not, then you will face all the disasters in the world in addition to your mental ill condition. The other thing I would say is about awareness. As you mentioned, awareness is very, very important, and I will go back to that. People do rely, and I would say this is very unfortunate, do rely in non-scientific reasoning, do rely on non-scientific explanation of what's happening to them. So therefore they go and approach different kind of treatments that doesn't work for them. And I could say that we have witnessed people getting killed in those treatments, people beaten to death because of treating the evil inside them or treating the jinn inside them. So that's something we should not ever, ever encourage because it is harming people with mental health, people with mental disorders. So that's something, awareness will prevent people from approaching those kind of treatments.
So they self-medicate.
Exactly, yes, yes. And of course we do encourage spiritual ways, for example, yoga, different kind of spiritual methods, but not beating a person, not physically treating someone for something that is not treatable by physical harm or pressure on their bodies. And that's something happening a lot in the Middle East.
Well, thank you, Gona.
Okay.
Well, that's all we have time today for, unfortunately. As you've heard, negative attitudes toward mental health in the Middle East are heavily influenced by a variety of factors. If mental health is discussed in a more positive way through social media, religious leaders within their communities, and education in schools, then perhaps people would feel encouraged to talk more openly about their suffering. Hopefully this will pave the way to a better understanding of mental health and overcome the paralyzing stigma, whether social or self-imposed, that are preventing adequate healthcare systems being established in the region. I'd like to thank all my guests on today's show, Dr. Laith Nasser, Sheikh Zayed Al-Ubadi, Dr. Sama Jabra and Dr. Inka Weisbecker, and of course my studio guests, Gona Saeed and Dr. Najem Al-Falahe. Thank you for watching. Until next time, goodbye.